Good morning, good afternoon, good evening. Hello, everyone, and welcome to today's live broadcast, Cancer Biomarkers in the Breast. I'm Alexis Krause of Labroots, and I'll be your moderator for today's event. Today's educational web seminar is brought to you by Labroots and sponsored by Agilent. For more information about our sponsor, please visit their website at agilent.com. Now, let's get started. I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click on the Submit button. You can also submit any technical issues here as well. I'd like to now introduce our presenter, Dr. Michael Phillips, Professor of Medicine at New York Medical College and CEO of Mensana Research. For a complete biography on our presenter, please visit the Biography tab at the top of your screen. Michael, welcome, sir. You may now begin your presentation.
Well, thanks very much for the introduction. I'm going to be speaking today about cancer biomarkers in the breast. Now, breast tests have been around for a very long time. In fact, they started in ancient Greece. Hippocrates, more than 400 BC, said to his students, smell your patient's breath. Well, you can tell a lot by smelling somebody's breath. For example, patients with diabetes, their breath smells like rotten apples. That's mainly because of acetone. Patients with kidney failure have a urine-like smell in their breath. That's because of amines. Patients with liver failure have this wonderful expression, fetor hepaticus, the stench of the liver, mainly due to sulfur compounds. Patients with a lung abscess have a sewer-like smell in their breath. They smell like sewers for the same reason that sewers smell like sewers, because of the overgrowth of anaerobic bacteria. And finally, nutrients. You can tell if any of your colleagues have had any garlic or alcohol for breakfast. Fast forward 2,000 years to France in the late 1700s, which was the dawn of the scientific period of breath testing. Lavoisier, the father of chemistry, was the first man to discover carbon dioxide in the breath. Now, if you look at this picture, you can see Monsieur Lavoisier standing on the left. On the right is Madame Lavoisier recording it all for posterity. There's this unfortunate subject sitting down, blowing through this high-resistance system. And this gentleman is blowing through a large container of lime water, calcium hydroxide. And after he's been huffing and puffing for several minutes, they observed a fine, milky white precipitate in this container. This is calcium bicarbonate. Now, this was the first evidence that human beings excrete carbon dioxide in their breath. Kids do it at grade school these days, but back in the late 1700s, this was hot news. This was the first evidence that human beings take in food, burn it metabolically, and put out carbon dioxide as a product. This, in fact, is really the basis of our whole understanding of biochemistry and of human metabolism. Unfortunately, it didn't do Lavoisier much good. He had his head cut off in the French Revolution. That had nothing to do with breath testing. That was because of his day job as a tax collector. Fast forward another couple of hundred years, and the modern period dawns in, of all places, Indianapolis on New Year's Eve, 1938, which was the first time that balloon breathalyzers for alcohol were deployed. And this they found is a very effective technique that's still with us to this day, and to identify revelers who maybe reveled a little bit too much. The modern period, though, of microanalysis of breath started in 1971 with Linus Pauling. Not only did he win 2 Nobel Prizes, he also performed the first microanalysis of breath. What he did was he concentrated normal human breath in a cold trap and then analyzed it with gas chromatography, which was a fairly new technology at the time. And he discovered that normal human breath contained more than 100 VOCs, or volatile organic compounds, all in very low concentrations, around about parts per billion. Now, how do these compounds get into the breath? Well, you can think of the lung as containing an alveolar membrane, and I've shown it here as a tennis court because if you spread out the alveolar membrane in the normal human lung, it's very large. It covers an area roughly the size of a tennis court of more than 100 square meters. And this permits volatile organic compounds to be inhaled from the air, such as volatile anesthetics, and it comes from the air across the membrane into the blood, or else they go in the opposite direction, such as ethanol goes from the blood into the air. One breath, these days we know, contains more than 2,000 different volatile organic compounds. I've broken down the technical challenges to breath testing into 3 categories. First, we have to collect the breath sample, then we analyze the breath VOCs, and then we interpret the data. Now, you might think that collecting the breath sample was the simplest part of it all, but in fact it's really the most difficult. You might think, well, anybody can blow up a balloon. The problem is that breath biomarkers are exhaled in parts per billion concentration, which means that even in so-called clean balloons, background contamination is a problem. You can buy very expensive clean Tedlar bags, but they're not really clean when you get down to levels of parts per billion. So let's go back to Indianapolis, 1938. Do you remember the breath balloon? Now that balloon was way too dirty for volatile organic compounds in parts per billion. The reason is that these balloons are contaminated with plasticizers and adhesives. However, we developed a way to make these balloons, or any balloons, chemically clean. What we've done is we've gone back to the future. We've taken a very old technology and we've developed this device called the breath bag, which is free of volatiles at parts per billion levels. Here's the secret. Well, it's not really a secret, of course. It now has a US patent. But we take a regular balloon and we put into it a strip of paper that's impregnated with activated carbon. This strip sucks up all the volatiles in the bag. And if we leave it there overnight and then remove the strip before collecting the breath, we find that that bag is chemically clean down to parts per billion levels. And this, for the first time, has provided low-cost, high-quality technology for collecting breath volatiles. It's now possible then to mail in breath tests. We can send this out as a kit to a user. They inflate the balloon and then send it back to the lab for analysis. So that brings us then to the second step, analyze the breath volatiles. There are several different ways of doing this. The method that's really the method of choice in most labs these days is to use gas chromatography. Gas chromatography provides a long column which separates out all of the VOCs, and as they come out at the end of the column, it can then be detected with various different kinds of detectors, such as mass spectrometry, flame ionization detection, or surface acoustic wave detection. However, there are other methods of measuring compounds in the breath. You've probably heard of e-noses or electronic noses. Sniffer dogs do a great job of it, and so too does infrared spectrometry. But for most laboratory applications, gas chromatography is really the method of choice. When you use this with some advanced gas chromatographs, here's a chromatogram using two-dimensional gas chromatography with time-of-flight mass spectrometry. You see a huge number of samples here, peaks I should say. We see more than 2,000 different volatiles in a single breath. This is excellent for biomarker discovery, but a bit expensive for routine use. One of these instruments will set you back more than $300,000. We use now what we call the BreathX system, which provides very low-cost analysis using a surface acoustic wave detector. The first step, as you see at the top, is to collect the sample. You use the ultra-clean balloon. Very simple to use. It can be used anywhere, say in a home or a clinic. This is then used either at the point of care, or it can be sent to a lab for analysis to analyze the sample using a user-friendly instrument with automated analysis. The results of that chromatogram are then analyzed. A server applies algorithms for different diseases, sends a report to the user, and this cycle can be completed in approximately 10 minutes. Now, this is a video showing how we actually analyze the sample in the lab. You see the technician takes the bag and cuts off the tip of it and puts the bag over the intake nozzle of the gas chromatograph. That device sitting on the left is a gas chromatograph with a surface acoustic wave detector. And you can see that that bag is deflating because a pump inside the gas chromatograph is pulling out the sample and capturing it onto an internal trap which has got 10x. And that's completed after approximately 2 minutes, and then the instrument automatically switches over and puts the sample through the chromatography column. It's a fairly short column, only about 1 meter, so results you see the results very quickly, and the peaks start coming out very promptly. So we'll just watch that for a few seconds. And after approximately 30 seconds, it's half done. It takes about 2 minutes to be completed. And you can see this is a 2-minute chromatogram. We see approximately 50 to 60 VOCs. It's not sensitive at these big benchtop devices, but that's generally good enough for most clinical applications. The third task here is to interpret the data. The challenge is to find the signal buried in the noise. Because we're using modern technology, we're going to see thousands of different volatiles in that bag, but only maybe 10 or so of them are significant for a particular application, such as being a cancer diagnostic. How do we do that? I'm going to show you more about that, and we're starting now with the breath test for lung cancer. The background to this is that this publication appeared in the New England Journal of Medicine in 2011. It came from the lung cancer screening group, and they reported reduced lung cancer mortality with low-dose computed tomographic screening. This was a huge study. It had more than 53,000 subjects. They randomly assigned people to be screened either with chest CT or LDCT, low-dose chest CT, or also chest X-ray. And they found that they could reduce mortality 20% in the group that had a chest CT. Now, this was regarded as very big news indeed, and has resulted in a huge expansion in screening programs. However, lung cancer screening does have some problems. Many of the smokers who need LDCT often don't get it because they fear the test, they fear the radiation hazard. It's got a very low yield. It takes more than 50 of these chest CTs to find one cancer. It's insensitive to early disease because it doesn't pick up lesions much smaller than 1 centimeter in diameter, and by which time the cancer has got more than 10 to the 10th cells in it. Also, it has a high false positive rate, and that's resulted in a lot of over-investigation and over-treatment. Now, consider what actually happens in the lung. Lung tissue damage of any cause can do two things. It causes a lesion that's visible on LDCT, but it also causes oxidative stress. Now, in oxidative stress, a cell starts manufacturing reactive oxygen species, or free radicals, and these are compounds that have got an unpaired electron in the outer valence shell. These are very, very powerful oxidizing agents. And you see here what's happened with polyunsaturated fatty acids, PUFAs, in cell membranes. These are oxidized and then broken down in a series of steps. And at the end of this series of steps, it's broken down to much simpler compounds, alkanes, straight chain N alkanes, such as pentane, methane, and so on. And these are excreted in the breath where they provide biomarkers of disease. We've reported several studies of breath tests for lung cancer over the years. However, even though these tests were a bit different and all of these studies were different, the experimental design was essentially very similar in all of these studies. We started out with two groups. The subject group, and this is a group that's got cancer that's proven by a biopsy and under a microscope, so we know that really is cancer, and a control group that has got no cancer at all. We then go through two phases, the model building phase, which is unblinded, and the model testing phase, which is blinded. In the model building phase, we identify the accurate biomarkers of cancer, and then we combine them into a predictive algorithm. Then we go on to the model testing phase, and we test the accuracy of that algorithm, usually in a new set of subjects. And we want to determine their sensitivity, specificity, and predictive value, and I'm going to explain what all of those terms mean. Now, first thing we have to do is identify the accurate biomarkers. And the way we do it is we display the data in what's called a receiver operating characteristic, or a ROC curve. And this is a plot of the percentage of true positives versus the percentage of false positives. Or we can relabel that. The percentage of true positives is the sensitivity of the test, and the percentage of false positives is 1 minus specificity. This curve gives us an enormous amount of information about whether your test is any good or not. Now, if it's a straight line like this, an area under curve of 0.5, then your test is really no good at all, because it's not giving you any information any more than just flipping a coin. It could be either way, just p less than 0.5. However, as that test gets better, for any reason, when you're up to 0.6, you're now up to a fair test, which is not bad. It's like PSA and screening for prostate cancer. Then 0.7, reasonable test, like most we use in clinical medicine. 0.8, now a very good test. 0.9, an excellent test. And 1, a perfect test, because at that point in the top left-hand corner, you can see the true positive rate is 100% and the false positive rate is 0. However, there's always a problem here. You're out for a walk one evening, you look up at the sky, and you think, oh, look, there's a face in the clouds. Warning, beware of seeing faces in the clouds. And the reason is that faces in the clouds we know are illusions. Similarly, many statistically significant biomarkers can also be illusions, simply because their very large data sets can throw up apparently significant biomarkers just by chance alone. Now, this has been seen in many areas of research, in neuroscience, not just in breath testing, and has gained the name of voodoo biomarkers. How do we avoid having a voodoo biomarker? Well, there's a statistical solution, and the method we use is what's known as Monte Carlo simulations. That's to say, we take the whole data set, and instead of applying the correct diagnosis of cancer or no cancer, we randomly assign the diagnosis to disease or no disease. Now, when we do that, we get a plot. If you look on the x-axis here, this is the C statistic, or the area under curve of the biomarker ROC curve. And on the y-axis, this is the number of candidate biomarkers. Now, initially, when we've done our random accuracy with the Monte Carlo simulations, just randomly assigning to disease or no disease, this is what the curve looks like. You start up with a very large number of biomarkers, and then it falls to 0. Then we compare that to, what are we seeing? We use the measured accuracy with the correct diagnosis. If these two curves overlap, then you're really in trouble, because it means that you have no biomarkers that are better than random alone. However, if these two curves are different, as they are here, you take the point where the random curve has fallen to 0, and the difference between the two curves here shows you the biomarkers with the accuracy that are better than chance alone. And that overcomes the problem of voodoo biomarkers. We published a study, a volatile biomarker in breath predicts lung cancer and pulmonary nodules. This came out in the Journal of Breath Research in 2019. This was an NIH-funded, blinded, multi-center validation study. It was monitored with good clinical practice. And as before, we had two groups, the training set and the validation set. And using the methods I've just described, we identified a mass iron biomarker of abnormal chest CT. So we've identified a biomarker which we've called MAGIC, and that stands for Mass Abnormalities in Gaseous Ions with Imaging Correlates. And MAGIC, we found, is a biomarker of an abnormal LDCT. It's defined by its retention time on gas chromatography and also by its MZ ratio of the mass ions, and that stands for mass overcharge. We're not 100% sure of what MAGIC actually is, but we've identified it tentatively from the NIST library. It appears to be a 5-carbon alcohol, and it's consistent with an oxidative stress product. Now, when we evaluated the clinical accuracy of MAGIC, you can see here two curves I've shown you on the ROC curve. The red and the blue, two different laboratories analyzed the same samples, split samples from the same patients. And you see the results were really very similar. That in the area under curve was 0.81 and 0.77, very similar indeed, which means we got very good results with two separate laboratories analyzing the same samples. So where we stand with the MAGIC biomarker, we did a blinded study, we did duplicate assays at two different laboratories, and it accurately predicted lung cancer and chest CT. Here's where we stand with the BreathX test for MAGIC biomarker. We hope to apply it for pre-screening to predict risk of an abnormal chest CT and lung cancer. The current status is that US patents have been issued and pending. It has a CE mark in the European Union. Clinical validations are in progress, and we hope eventually to submit this to FDA for approval. Let's move on now to a breath test for breast cancer. Why is it needed? I need to explain to heavily male audiences that most women hate having a mammogram. There's a number of reasons for that. It's painful, they fear the radiation, and it can be embarrassing. They have to get undressed for it. The other thing about mammography is that it is a very low-yield test. Now, in this diagram here, I've shown you 300 women represented symbolically who are going in for a screening mammogram. Of these 300 women, 30 of them will have a positive result. That is, the mammogram will be reported as suspicious for breast cancer. They'll be called back for repeat views, and of this then, they'll find 6 that still look pretty suspicious, and they go on to biopsy. And of these, 1 has cancer. That's right, 300 patients to discover 1 case of cancer. The other side of it is, think about those 299 women who don't have cancer. They have to undergo radiation, discomfort, anxiety, expense, and all they get at the end of that is reassurances, by the way, you're not the 1 in 300 who's got breast cancer. Well, in 2018, we reported our first clinical evaluation of the BreathX system, though we had done a number of studies prior to this of breast cancer. We reported prediction of breast cancer with volatile biomarkers in the breath. We did these tests in 178 women. We had 2 groups, one with biopsy-proven breast cancer, the other no cancer, normal mammograms. Did this in 3 sites, one in Mexico, 2 in the United States, and we compared 2 methods, GCMS and GC-SAW. This is the number of human subjects we had. I shan't go through that. And here's the results. This is the ROC curve. And you'll see the blue here was with GC mass spectrometry. The red is GC-SAW. Not much difference between the 2 of them, 0.9 and 0.86, both of them giving excellent results. These are the best results yet reported for a cancer breath test. And just to put a bit of comparison in this, if you compare this, say, to mammography with film or digital mammography, they're generally reported around about 0.78. So the breath test is at least as good as, and possibly better than, a screening mammogram. This is the expected outcome if we screen large populations. You need to know 2 things, the positive predictive value and the negative predictive value. The positive predictive value is the true positives divided by all positives. So there's the true positives plus false positives. The negative predictive value is true negatives divided by all negatives. That is true negatives and false negatives. When we do that, we make a plot of the positive predictive value. Now, what comes out when we analyze the breath is what's called the discriminant function. That is, the algorithm applies interprets the chromatogram and generates a number that is called the discriminant function. And you'll see here that it goes on about 1 to 4. And as it starts off very low and then suddenly jumps up. So the PPV increases with the DF or discriminant function value and eventually rises to 100%. Now look at the negative predictive value. This is important because the negative predictive value is a rule-out test. It tells you if the person does not have cancer. And you'll see that it starts off very high and then falls down. And the negative predictive value is better than 99.9% at very low values of the discriminant function. So based on this, you can see that the risk of breast cancer increases with the discriminant function generated by the breath test. So as we start off from low to high, so does the risk of breast cancer increase. It stratifies the risk into 3 separate groups. If the discriminant function is less than 1, then there's a very low risk of breast cancer with a negative predictive value better than 99%. Green light, very low risk. What if the discriminant function is greater than 3? Well, then there's a high risk of breast cancer. Red light, and that patient should be investigated further. But if it's intermediate, between 1 and 3, it's an intermediate risk, well, that's an amber light, and what we can do is just follow up. So here's our conclusions. The breath tests have detected breast cancer. Several studies, not just our laboratory, have reported that breath biomarkers of breast cancer. and it's been shown in different laboratories using different methods. The potential benefits is that it could provide an accurate new cancer screening tool, resulting in fewer needless mammograms. Women would benefit because they'd have no discomfort and no radiation, and the healthcare system benefits from lower costs. I want to conclude with breath tests for biomarkers of radiation exposure. Now, the reason I included it here is that radiation therapy for cancer is very commonly employed. And there is a very variable biological response to radiation. In people who have chest radiation, approximately a third of them will develop radiation pneumonitis, or serious inflammation in the lungs, and this is unpredictable and life-threatening. So the solution could be a breath test for radiation biodosimetry that predicts the actual biological dose of radiation. The method here is that we're going to validate breath biomarkers of radiation exposure. We're doing this in two phases: in animals to confirm the proof of principle, and in humans to validate the dose response to radiation. Our long-term hope is perhaps we could predict radiation pneumonitis. We haven't achieved that yet. The scientific basis for this is that radiation of water generates free radicals and causes oxidative stress, as we've seen previously. This oxidizes the polyunsaturated fatty acids to N-alkanes, and again we see volatile organic compounds excreted in the breath as biomarkers of radiation. We've published several papers on this. We initially studied the Göttingen mini pig, and we've also done this in human studies as well. We recently completed an animal study in collaboration with our colleagues at Agilent, who provided us with a GC mass spec with mass spectrometry and flame ionization detection for this study. And this is what a breath chromatogram looks like. By the way, you can see the instrument there. And this is what a typical breath chromatogram looked like in our test animals. These were non-human primates. Just with the naked eye, you can see approximately 50 peaks in that chromatogram. But there's several peaks in there that are too small to be seen, but a computer algorithm picks them out very nicely, and we can see anywhere up to about 200 different peaks. Now, we looked at 5 non-human primates in this particular study, and I'm showing you here the average chromatogram, the mean of the 5 chromatograms before and after radiation. In blue, this is the mean chromatogram of breath before radiation, and here in red is the mean chromatogram after radiation. Well, you don't need statistics here. You can see that radiation produced some pretty dramatic changes. However, we did, of course, go through all of the steps that I've outlined before, such as the Monte Carlo analysis, and we found that many of these changes were statistically significant. And here's where we stand with the breath test for radiation. The pilot studies were successful in animals and humans. The biomarkers were consistent with oxidative stress products, and the hope is maybe it could predict radiation pneumonitis. And we are planning larger validation studies in humans. However, of course, I must emphasize, at this stage, this is for research use only. It is not an FDA-approved test. Now, this is the point in my presentation where usually I can hear members of the audience stirring restively and saying, well, if breath tests are so good, why isn't everybody using them already? Well, there's a reason for it. I have represented a breath test as a leaping lion here. This is the Mensana breath test. And that leaping lion wants to get its jaws into this juicy piece of meat here, the market. But in order for the breath test to reach the market, it has to jump through 3 flaming hoops. The first hoop is to demonstrate scientific validity, which we've done. The second hoop is to get FDA approval, which we haven't. And the third step is to get Medicare reimbursement, which you can't get without FDA approval. So this process, by the way, is much easier outside the United States because there are much lower regulatory barriers in the European Union. And we are very close to marketing the breath test for breast cancer in Europe. And indeed, we have 3 studies commencing there as we speak. So here's where we stand with breath testing. We have a very long product pipeline, some of them closer to fruition than others. And you'll see that we've included lung cancer, tuberculosis, breast cancer, influenza, counterterrorism. We've got many tests in the pipeline, some closer than others, and we do hope the cancer test will get there first. So thank you for listening so patiently, and I hope you will agree with me that this is breathtaking technology. Well, we've got a few minutes left, so we're open for questions.